Okay, so good afternoon. My name is Sarah Dorman. I'm an orthopedic surgeon from the UK, and I'm going to be talking on the neglected supracondylar fracture. I don't have anything to disclose. And just before we start, a little bit about me. So I undertook my training in the UK. I did fellowships overseas in Sydney, France, and Cambodia, and I have always had a global overseas interest. I also undertook some work in Kathmandu and in Malawi at the Bay Cure. My current practice, I'm based at Sheffield Children's Hospital in the UK, where I undertake general paediatric orthopaedics with a specialist interest in upper limb. In the centre picture at the top, you can see the Peak District, which is where I live, which on a sunny day is very beautiful. I also undertake some overseas work regularly in Cambodia 2 to 3 times a year as part of a specialist upper limb team from the UK and Singapore. I serve on the BSSH committee for global overseas work, and I also am a regular faculty member for AO Alliance for Africa for paediatric courses. So, what this lecture is going to cover, although the topic is the neglected supracondylar fracture, I am going to cover briefly the acute supracondylar fracture because what we know is that by and large, the best treatment for a neglected supracondylar fracture is trying to avoid it in the first place. I'm going to talk about some of the common complications and then strategies to deal with the neglected supracondylar fracture, largely related to supracondylar malunion. So when we talk about supracondylar fractures, what we're talking about is an extra-articular fracture of the distal humerus in a child. It tends to be in the metaphyseal region, and they come in all shapes and sizes. So you can see here at the bottom a relatively mild supracondylar fracture. At the top, hopefully you can see it. There's a more displaced supracondylar fracture, and depending on where you work in the world, you may get this situation in the bottom right where you get a severe supracondylar fracture that is neglected and presents with a healed malunion. The good news is, though, that most cases can be treated effectively, whether they're acute or neglected, and for the most part, don't require any specialist equipment. And that means that with careful clinical assessment, simple x-rays, and very good pre-op planning, these can be treated very effectively, even in low resource environments. So I am just going to touch briefly on the acute supracondylar fracture of the humerus. So we know that they come in all different sizes, and we often describe them based on the Gartland classification. So that's classification 1 to 4, with 1 and 2 being the more simple types. So typically 1 is an undisplaced fracture, 2 is displaced but has an intact posterior hinge, and for the purposes of this talk, I'm going to refer to those as simple fractures. And the reason that I say that is in most cases, these can be treated in a low resource setting with non-operative measures, such as a collar and cuff. So by placing these into a high collar and cuff or a long elbow cast, in flexion, ideally at least 100 degrees of flexion, between 100 and 120, no more than that in case you cause any compression in the antecubital fossa. But this helps with the fracture stability and with the fracture reduction. Now, in some places in the world, the type 2s may be treated operatively, but as I said, in most cases in a low resource environment, this treatment is adequate in the vast majority. For the difficult or unstable fractures, so the type 3s and 4s, where it's completely displaced and there's no intact hinge, or in a type 4 where it is multi-directional and unstable, so it goes from flexion into extension, these are unstable and usually require surgical treatment. And this is a case that I'm going to just talk through some tips and tricks for avoiding complications. This is a patient of mine who was treated several weeks ago, and you can see that this is a Gartland at least 3 fracture. The distal fragment is displaced laterally, and on the proximal fragment, you can see that there's a large medial spike, which in a minute you'll see has buttonholed through the brachialis. These fractures have a higher risk of neurovascular compromise, and in the context of having a neurovascular injury, that is an indication for more urgent surgery. In this case, you can see in the picture, there's what's called a brachialis sign, where there's puckering of the skin and bruising on the medial aspect of the arm. And this requires what's called a milking maneuver to try and push the brachialis muscle off that medial spine you saw. By seeing this sign, it does usually indicate that there's risk that you might have to open this elbow um, if there's anything trapped in the fracture site, or that they can be associated with neurovascular injury. And so need very careful preoperative documentation, not just of the pulse and whether they're pink or white, but also of their individual nerve status. So when treating these in theatre, the key to success is your setup. So I do it the same way every time. And for difficult fractures, I do it supine with an arm board. These fractures are very unstable and difficult to get reduced. The more times you manipulate the fracture, the more unstable it becomes. And anytime you move the arm, you're likely to lose the reduction. So for that reason, it's recommended that you position the patient supine with it on an arm board, but you move the X-ray machine to get your pictures. For the same reason, I always prep and drape before doing the reduction so that once the reduction is achieved, it can be immediately pinned. The steps for reduction start with longitudinal traction. And this is something that you have to be patient with and wait at least 2 to 3 minutes, ideally even longer. And I normally take an X-ray picture of an AP X-ray with the traction on situ. And the reason for that is to check that I've got it out to length before doing any further manipulation. Once I'm satisfied that I've got enough traction and that the fractures come out to length, at that point I will try and correct the coronal plane deformity. And in the vast majority of cases, as we saw in the previous X-ray, you're trying to push that distal fragment medially to reduce it onto the proximal fragment. After that, you're trying to flex up the elbow, pushing on the olecranon fossa, and you may need to put the forearm in either supination or pronation depending on which one looks best on the X-ray. Once you've got the fracture reduced, then you can get a shoot through AP, as you can see on the top right corner, and then advance your first lateral wire. There's lots of different opinions in terms of the best wire placement and whether lateral wires or cross wires are beneficial. In my practice, I always put 2 lateral wires, then screen it and add a third medial wire should it be required. I really like this picture from Abzug's book in 2018, and what I really like about it is it shows a really nice wire placement in terms of making sure you have your wires through the capitellum on the AP and the lateral views. One of the common mistakes I think that people make is, hopefully you can see my arrow here, but commonly people put their wires on the lateral X-ray too far posterior and you don't get as much good purchase in the distal fragment, and you're more likely to have a wire construct that fails. Sometimes you run into supracondylar fractures that are particularly unstable. There are a couple of strategies that you can use to overcome this. So one is that you can use a joystick technique. Now in this picture it has a wire medial and lateral. In my practice I tend to put 2 lateral wires, but you can pass these just into the distal fragment. That then gives you a joystick or a control to try and reduce the distal fragment onto the proximal fragment if you're struggling to get things back closed. Other options include a posterior intrafocal pin. This is also known as the Kapanji method, similar to what you might have seen in a distal radius. In this technique, you do a small posterior stab incision, pass the K-wire into the fracture site and use it to lever down the distal fragment. And this can help stabilize your distal fragment until you get your definitive wires in. When you do pass this wire in, you normally pass it in intramedullary and don't pass it through the anterior cortex. And then finally, if you've manipulated it a lot and it's become multi-directional and unstable, or if it was a flexion type to begin with, you have to adjust your reduction technique slightly. If it's going into flexion, it helps to put a crepe roll behind the humerus, and then you flex the elbow to 90 degrees and use the anatomy of the ulnohumeral joint to push backwards, and that helps push the distal humerus back into a better alignment. And then for me, the most crucial part of the acute supracondylar fracture treatment is assessing the stability live. So I always do a live screen of flexion extension once my wires are in situ to check that the fracture isn't moving. I also screen it, and this is the same fracture from earlier. I screen it in valgus and varus stress to make sure the fracture isn't opening up. I take oblique column views, and I do an internal rotation stress view. And what that internal rotation stress view is looking for, and this is a really nice example you can see in the central picture, somebody has done two lateral wires, and as they apply the internal rotation stress, there is a medial spike that appears, indicating that this is rotationally unstable. And in the picture on the right, you can see that having added a medial wire, the rotational spike is no longer present, indicating that it's now stable. Post-operatively, I typically put them in a back slab rather than a full cast, but they're elevated on the ward. They have a recheck of their neurovascular stratus by getting them to do a thumbs up for the radial nerve, an OK sign for the AIN and median, and spread the fingers like a star hand to check the ulnar nerve. In many cases, you'll be working in an environment with significantly limited resources, and it may be that you have a super like this that you simply don't have the resources to take it to theatre. And there are other options. This is not something that we routinely do in the UK anymore, but it was a long-standing practice in the years gone by. And you can apply straight arm traction. And this is a really nice example from one of the BOA guidance. Now, this is a child who has had straight arm traction applied, simple skin traction with a bandage overwrapped. You can see here that there's a pulley system, the weight on the side. The bed has been elevated on the affected side to allow the body to the counter traction against the pulley system. With the arm in a straight and elevated position, adjust the pulley and adjust the abduction or adduction of the arm to correct the varus. And this is a really reliable technique in the absence of surgical intervention if you don't have it available in your unit. So moving on to what can go wrong. Well, we know that there are lots of common complications associated with supracondylar fracture. The most common one is secondary malunion and subsequent deformity. In most cases, if a deformity is present, we like to think of deformity in three planes. So we like to think about the coronal plane, the sagittal plane, and the axial plane. And in a neglected supracondylar fracture, the most common deformity seen is a cubitus varus, extension, and internal rotation deformity. And sometimes they may be present in isolation or a combination of all three. Cubitus varus, if you read in textbooks, you will also often see that it's referred to as a largely cosmetic deformity. And in many cases that may be true. However, there are other secondary complications associated with this deformity, which include late ulnar nerve dysfunction. The change in the bony anatomy of the elbow can predispose children to lateral condyle fractures in the future. And much later on, and in severe deformities, sometimes they may get posterolateral rotatory instability of the elbow, which is due to chronic thinning and attenuation of the lateral ulnar collateral ligament. And of course, other complications that occur, which I'm not going to talk in depth about on this talk, but are important to acknowledge, is that there can be vascular compromise. Compartment syndrome is not uncommon, particularly if there is an associated forearm fracture in addition to the supracondylar fracture. Nerve injuries are common, both from the time of injury, but also iatrogenic complications. There can be avascular necrosis, usually of the trochlea. And of course, there can be superficial or deep infections, particularly if they've already had treatment or pin site infections, or if the fracture has previously had an open wound. So for me, the key principles of understanding how to treat a supracondylar malunion involve going back to basics. So first of all, understanding what the expectations of the child and the family are, and understanding whether there's a clear goal and reason for intervention. And that reason, so it could be to try and address a functional problem that the child has, or it could be that they've got a severe deformity and you're trying to reduce the risk of a late complication, as we mentioned on a previous slide. I would say that the threshold for intervention, in my experience, is very different depending on local culture. I find that my patients in the UK are much less tolerant of small deformities, largely because of cosmesis. Where when I work in Cambodia, I who tolerate big deformities because functionally they've learnt to adapt. And this is just an example of a child from Cambodia. So this is a 7-year-old who came with a delayed presentation. It was their non-dominant arm. They were originally treated for the fracture in a bamboo splint by a traditional healer. And the first time they presented to healthcare professionals was with this healing supracondylar. You can about see that there are some skin changes on the arm. That was because there was some skin breakdown in relation to a very tight bamboo splint that was originally on, but there was no signs of any deep infection. And you can see that functionally, actually, he didn't have much in the way of hyperextension, but he had a bit of loss of flexion, but his carrying angle was okay. This child was offered intervention, but ultimately, both him and his family decided that he was able to compensate with wrist and his shoulder, and so they decided not to have any treatment. When treatment is undertaken, the vast majority, or the mainstay of treatment, is through a corrective osteotomy of the distal humerus. Now, in order to do this, you need to have a very clear understanding of what the deformity is. So, the components of the deformity, the severity of the deformity. So, and you need to understand both of these things in order to have a surgical strategy in which you can address this. I'm going to talk about how I assess the deformity, and this is predominantly done through clinical examination and X-ray assessment. So going back to looking at the different planes of deformity, I normally start with a coronal plane assessment. So in a normal child, the arm is in slight valgus, and so you can see this is actually my son, and you can see he's got a normal arm on both sides, and his resting position is in slight cubitus valgus. Now, when you're assessing this, and when you're assessing an elbow, it's common for cubitus valgus or varus to also have a problem with fixed flexion of the elbow or hyperextension. And in order to avoid what we call a parallax error, so a parallax is where there's an apparent difference in the direction of the object seen from two different points. And what that's really saying is, if you look at this picture of my son, you can see his arms are full extension and he's got symmetrical carrying angles. Central picture, he's simulating a fixed flexion deformity of his left elbow, and it's giving the appearance that his carrying angle is increased. But when I match the position of his elbows on both sides, the carrying angle is symmetrical. So this is really to point out that if you have a fixed flexion deformity or a hyperextension deformity, you have to match the positions of the elbows in the sagittal plane to be able to accurately assess the carrying angle. Otherwise, you'll misinterpret, either overestimate or underestimate the deformity. And this is a clinical example of somebody with a cubitus varus deformity. So you can see a normal carrying angle on this side, and on this side, you can see that it's in cubitus varus or a gunstock deformity. Moving on, you want to assess the component of internal rotation. So if you remember from before, we said that the components are used cubitus varus, increased internal rotation, and hyperextension. So to assess the degree of internal rotation, you get the person to put their arm behind their back, and the examiner holds on with a finger on the medial and lateral epicondyle. And with the patient bending forward, you measure the angle between the back and the forearm. This, in most cases of a neglected supracondylar, the internal rotation will be increased, and you compare it to the contralateral arm. Finally, you assess the sagittal plane. So in this example, you can see on the left side that there is a hyperextension deformity of the elbow and a reciprocal loss of flexion. And I normally get them to do it facing me with the hands up to the ceiling and then touching the shoulders, because this is the easiest and most reproducible way compared to the contralateral side. And where possible, if you have the resources in your hospital, I would recommend using a goniometer measurement, because this gives you an accurate representation in terms of degrees of the range of movement, which you can compare to the other side, which helps you calculate how much correction is needed later. And the landmarks for this are the acromion process, the lateral epicondyle, and the radial styloid. If you don't have access to a goniometer, you can take clinical pictures, and this is an example of a clinical picture I took of this child, and I've used a simple free app on my smartphone to use a protractor to measure the angles, and you can see just about it's 34 degrees on this side and 58, so there's a difference of 24 degrees measurement based on this. Moving on to X-ray assessment, same principles, assessing the coronal and sagittal plane on the X-rays. On the coronal plane, or the AP view, the most commonly looked at measurement is the Bowman's angle. And this is measured by measuring the long axis of the humerus and also the long axis, so a line across the capitellar physis. And on the left-hand image, you can see this is a normal Bowman's angle, which is usually between about 65 and 80 degrees. On the right side picture, you can see indicated by the yellow angle, this is increased, indicating that there's a varus deformity within the distal humerus. The most reliable way to measure whether it's increased or decreased is to do an X-ray of the normal elbow, and this will give you the most accurate representation of what the normal Bowman angle is for that individual child. And anything more than 5 degrees is considered a significant difference. Looking back at the patient we saw earlier, you can see that they have cubitus varus, and having measured it on the X-ray, you can see I've measured the long axis of the humerus here and the capitellar physis, and it's measuring as 102 degrees, which is higher than the upper limit of normal of 80, indicating a varus deformity. Similarly here, this is another example. I've measured the long axis of the humerus, the capitellar physis, and the Bowman's angle is 90 degrees, again indicating a varus deformity. Other measurements you can undertake on the AP plane is the ulnohumeral angle, which is the X-ray equivalent of the carrying angle of the arm. And in this case, you measure the long axis of the humerus, as well as the long axis of the proximal ulna. And you're looking for the difference here. And again, it's very much individual. And so comparison against the normal arm in the individual patient is the most accurate reflection. And in most cases, I would try, my standard approach to X-rays is to try and do long arm, so humero-ulnar views, including the whole of the humerus and the forearm of both arms on the same X-ray film. And by doing this, you can accurately measure both the Bowman angle and the ulnohumeral angle accurately on the same film, which allows much easier comparison. In this case, you can see that the patient actually has a cubitus valgus deformity on the right side. And actually, this is coming from the proximal ulna in this case, but is used as an example where you can see quite nicely the difference in the ulnohumeral angle on the right side compared with the left side. And as we said in the clinical examination, you need to match the position of the elbow, flexion and extension to make sure that you're getting like for like images. Moving on to the sagittal plane. You can measure the lateral capitellar humeral angle. So you draw a line down the anterior humeral line, and this anterior humeral line in normal cases will pass through the center of the capitellum. You then draw a line along the lateral capitellar physis, and you get this angle. As this angle increases, more extension deformity is present. Similarly, a slightly different way to measure it is if you measure the long axis of the humerus and the long axis of the capitellum. And here you can see the normal angle. And as this angle decreases, more extension deformity is present. And this is the example that we saw previously of the boy with the hyperextension deformity. You can see here I've measured his Bowman's angle, which is normal, so it's predominantly extension deformity. And we look at so this is an example of the normal lateral capitellar humeral angle, and you can quite clearly see here that it is significantly increased to almost just beyond 90 degrees. He does also have some translation posteriorly. Similarly, when we measure the humerocapitellar angle, this is normal, and you can see it's passing outside the bone down here because of the degree of translation, but this angle is much reduced, also indicating an extension deformity. And just for interest, this was him having had no treatment and he continued to have some remodeling up to the age of 16. So, how do I do a distal humeral osteotomy? So, there's lots of different techniques described, and they include a lateral closing wedge, dome osteotomy, or more complex osteotomies, which include step cut osteotomies and different geometric cuts. What you do often depends on surgeon experience and the resources that you have available. You also need to think about what the coexisting problems might be. So, is there long-standing remodeling or dysplastic changes within the joint that might affect your surgery? Do they have a neurovascular deficit? And are you going to do surgery at the same time to address that? Or is that possible? Is there a soft tissue problem? And if they've had previous surgery before, then the surgical incisions might dictate the approach that you can do, and therefore might dictate the type of osteotomy you can do. But in the vast majority of cases, my recommendation would be to keep it as simple as possible. So in my hands, I tend to do a lateral closing wedge. And I set this up in exactly the same way as I do for my acute supracondylars. So I undertake it supine with the arm extended. I use a small high tourniquet and I tend to use a sterile tourniquet because if I have a problem with access, I can remove it. I do meticulous pre-op plan and I still do a traditional on paper plan. I take a clinical photograph of both arms pre-operatively and I tend to display it in theatre if I can. And that's partly because once you've prepped, you can't see the normal arm anymore. As we've already seen, I very carefully calculate both clinically and radiographically what the angles of the normal arm are. I then calculate what the clinical and radiological deformity of the neglected ulnar are. And this allows me, by calculating the normal and calculating the abnormal side, this allows me to calculate the desired correction angle for the cubitus varus and the extension and the internal rotation, depending on what components are present. I then mark out all the important landmarks. So I mark the joint line, I mark the physis, I mark the top of the olecranon and fossa. I also mark the long axis of the humerus in the forearm. And I draw this on the skin because it helps as a visual marker to make my surgery easier. I do a simple lateral approach to the distal humerus along the supracondylar ridge between the triceps and biceps. You need to take care proximally not to injure the radial nerve. And once I'm down on the periosteum, I make a nice longitudinal in the periosteum off front and back. I then use either Homans or a small McDonald's to get around the front and the back of the humerus so that I have a safe plane in which to work. And you can see here, this is a nice approach to then begin thinking about making your osteotomy cut and putting some guide wires in position through this approach. The type of osteotomy that I do depends a little bit on the type of deformity that I'm treating. In cases where it's predominantly varus deformity, I tend to do this technique. And what you can see is that I've placed wires in from the lateral side here, one just above the olecranon and fossa, and then the proximal one dictates the degree of correction. Intraoperatively, I use one of these. So this is a metal wedge, which is sterile, and usually the correction is in the degree of 20 or 25 degrees, but again, depends on what you've calculated preoperatively. But I can use this to check that the wedge I'm going to take out is the correct size. You can see that two lateral wires have been pre-positioned in the lateral condyle, and you place these before doing your osteotomy, so that you can maintain control. Once you've done your osteotomy and removed the wedge, you can then flex up the elbow and valgasize it like you would for a supracondylar fracture. And then your pre-positioned lateral wires can be passed across to engage the medial cortex. The main thing to consider for this is when you do place those initial lateral condyle wires, they need to be quite vertical because you need to be thinking about where your correction will end up to make sure you're going to get bicortical purchase. Once you've passed them and you've achieved bicortical purchase, you can then do a stability screen to make sure that your construct is stable enough. Sometimes you need to modify what you do. Now, this picture is actually a picture of a 3D reconstruction and a specialist 3D jig. Now, the purpose of this picture is just to demonstrate that if you have varus and extension, that's a biplanar deformity, so a deformity in two planes that you sometimes might need to adjust your cuts for. Now, in my hands, doing a single osteotomy to correct two deformities is something I find challenging. And so for me, I do a modified technique. So I do it exactly the same way as I've already described. So same approach, I just still do my lateral wire pre-positioning, but because I want to correct both hyperextension and varus, I do this by doing two separate cuts. The first cut I do to address the hyperextension, and the second cut is to address the varus. And so, similar to what we saw in the previous x-rays, here you can see in this diagrammatic picture, the blue lines represent my lateral wires, which are pre-positioned. But my my K wires, which are acting as the cutting jig, in this case, one is above the olecranon fossa, and the other one is parallel to it proximally. And these wires are placed parallel in both the AP and the lateral plane. And basically what they do is they mark the proximal and distal extent of your osteotomy. Then looking at it from the lateral view, you cut an anterior closing wedge with an intact posterior hinge. And this allows you to correct the sagittal plane deformity, so the hyperextension deformity. You're in a situation where you've got this. So you've removed the wedge, you've corrected the hyperextension. Your cortices are now parallel with a slight mismatch anteriorly due to the difference in size, but you've still got your two parallel K wires. You can then remove the proximal K wire and readjust it, keeping it in the same plane on the lateral view, but this time correcting for varus, similar to what we did in the original surgery. And this time you cut bone only off the proximal fragment and only on the lateral side, and this will then correct your varus deformity. And then it's fixed like this. So the lateral wires are advanced across the osteotomy site. You check for stability, and if you're concerned about stability, you can add a third wire. You can add it through the medial epicondyle, similar to what you would do for a supracondylar fracture, or if you've already got a lateral wound, you can also pass it proximal to distal. The wires are then cut and buried, and the patient is put into a long arm plaster in the post-operative period. So in summary, largely speaking, the neglected supracondylar fracture can be avoided. Early prevention is key, and even very basic interventions in acute supracondylar fractures can prevent significant complications. Deformity correction is important. It's often a deformity in multiple planes, and the key is to keep it as simple as possible. You need to be able to assess the deformity carefully in the coronal, sagittal, and axial planes, both on examination and on simple x-rays. And once you've got that information and you compare it to the normal side, you can develop a clear intraoperative strategy and work out how much you're going to correct the abnormal side and end up with a successful result. So just to acknowledge, these are two of my colleagues, Mr. Nick Green on the top and Mr. Fernandez, who provided some of the images from this presentation and a short summary of the references that have been used. Thank you very much.